the more people that we have with endometriosis that are able to contribute their tissue from around the world, the better we're going to understand this disease.
My name is Isabel Donnelly, and welcome to The Sober Spill. Today I'm here with Dr. Danielle Luciano. For the people that don't know you, who are you?
So I am the current interim chair of OB-GYN at UConn Health. I am also a fellowship-trained minimally invasive GYN surgeon, which means basically I am fellowship-trained to take care of patients with benign GYN conditions, mostly endometriosis and uterine fibroids. And then I am also co-director of the state-funded Connecticut CT EndoRISE, which is a program that raises awareness, educates, supports, and does research on endometriosis in Connecticut.
That's so many titles. It must be so much to remember.
Well, it keeps me, I try to keep them separated into their little boxes.
Yeah, smart. You compartmentalize.
Exactly.
So we asked you to be on here because I wanted to talk about the work you guys do, endometriosis, because as we know, it's about like 1 in 10 women who struggle with this. And we have a lot of alumni I know that have gone through this, that come through struggling with this, can feel very isolated in it. And there are a slew of issues that intersect that can make recovery, especially early recovery, really challenging when you have this kind of, it can feel very nihilistic having this like thing that's like, okay, it's forever. We also like don't have a lot of awesome solutions for you. So I think maybe research is helpful. So how did EndoRISE come to fruition?
So Representative Jillian Gilchrist from West Hartford decided that she wanted to start a working group in the state of Connecticut to look at endometriosis. She had some personal associations with women who had endometriosis, and the more she looked into it, the more she realized that this was obviously a very significant disease that affects 1 in 10 women in her state. And she couldn't believe that there wasn't something being done about this. So she put together the Connecticut Endometriosis Working Group, which is an amazing group of women and men that are focused on so it has patients in the group, it has advocates in the group, it has doctors in the group, researchers, legislatures, administrations of hospital organizations, different administrators from like the Department of Public Health, like a bunch of people on there that really just wanted to work together and figure out ways to address endometriosis in the state. And so in 2023, we proposed, or actually 2022, we proposed a bill to the state of Connecticut to set up this EndoRISE program. At the time, it wasn't called that. It was just called the Endometriosis Data and Biorepository and Education Program.
I can see why it moved to EndoRISE.
Yes, it was a little too long.
Yeah.
So we put in together this proposal, and it was unanimously passed by both the House and the Senate in 2022 to set up this program. And it was amazing. And they gave us a year to put together the program and what we wanted it to look like. So for a year, the Endometriosis Working Group with the helps of Jackson Labs and UConn Health, who were designated as the people to kind of lead the education and research and support, we put together this program and again presented it with a budget to the legislature. And again, in June of 2023, it was unanimously voted for and passed as a 2-year program to raise awareness about endometriosis and to educate and to advocate and to do research for our patients. And one of the things that's really exciting about our program is that not only do we do education and awareness, but we actually are leading the way in research on endometriosis in Connecticut. And what we did was we joined the World Endometriosis Research Foundation biorepository. So now when patients donate tissue after their surgery, tissue that would otherwise be discarded, to the biorepository, it not only becomes part of Connecticut's biorepository, but it becomes part of the World Endometriosis Foundation biorepository, which means they're helping to do research all around the world on endometriosis, because we know that endometriosis is a disease that affects 1 in 10 women all over the world. It doesn't matter what your cultural background is, what your ethnicity is. Endometriosis is equal opportunity in that way. And anybody that has a uterus or ovaries is at risk for the disease. And so it also presents differently in everybody. So the more women, the more people that we have with endometriosis that are able to contribute their tissue from around the world, the better we're going to understand this disease.
And it's exciting to know that there is research happening. I don't know if you've seen, I recently saw a study that came out that it was a study done on like the impact on male partners. Did you see that? And that felt so like upsetting, where it's like there hasn't been, or there's a study on like how attractive women with endometriosis are.
Yes.
I don't know if you saw that, where it just feels very like male centric, and it's like this is what is available. So it's incredibly exciting. And so the biorepository, when you have any client that goes in and ends up receiving surgery, they have the option to be a part of this.
Yeah, so right now our only site is at UConn, but we are in the process of expanding to other sites in the state in hope to collect as much tissue from all over the state, diverse. The more diverse our samples are, the better we're going to be able to understand the disease.
And how did you personally get into this? Because this is obviously, as far as medicine goes, this can be a more niche part of it. I've been to doctors before that I have to explain what this is to them.
So I did my residency like all OB-GYNs, and then I chose to do a 2-year fellowship in minimally invasive GYN surgery, which actually is being changed to complex benign gynecology. But at any rate, I decided to do a fellowship. And part of the reason I decided to do that is because I wanted to treat women with these complex diseases, and I wanted to understand the disease better. I mean, I like delivering babies and I like doing all that other stuff, but I really wanted to specialize in treating women with endometriosis and uterine fibroids, pelvic pain, abnormal uterine bleeding. And so I did that extra training. And that's and then I spent many years working on that, and we set up a center of excellence in minimally invasive surgery at UConn. I hired other fellowship trained surgeons to join me. We set up a multidisciplinary team, and then I decided I wanted to start doing some research on it. And Dr. Courtois, who is my co-director, and she's the research side of our 2 arms. She reached out to me actually before the endometriosis working group even started, and said, I want to do some basic science research on endo. Do you want to do it with me? And so we started doing some basic science research, and I just realized, there's just so little research on endometriosis, and it's really important that we as clinicians work with the basic scientists and give them this tissue so that they can study it and they can learn from it. We don't even know basic stuff about endometriosis. We don't know why it grows. We don't know how it grows. We don't know why it grows in certain patients and not in others. We don't know basic stuff. We don't know why it recurs. So the only way to understand that is for us as clinicians and surgeons to first recognize that patients have endometriosis, treat them, excise their lesions appropriately, and then give them to the basic scientists so that they can hopefully figure it out for us.
Yeah, and as you know too, there's like a 7-year gap usually before someone gets diagnosed, like when they first start experiencing symptoms, complain of pain, and things get dismissed, and it's almost like they're still diagnosing people with female hysteria, which I think is so funny, where they're like, oh, it's anxiety. Like, do you think it's anxiety?
Yeah.
And it takes so long to get to the point where you have a doctor that is believing you, and that can be incredibly invalidating for a lot of people. Like, it can be a challenge for them to continue to advocate for themselves to even get somewhere where they'll find treatment.
Oh, I hear that story all the time. I mean, the number of times that I hear patients tell me their story. I mean, I saw a patient yesterday who is 30 years old, and she has been having painful periods since she was 15 years old. And people have just blown her off. They've told her it's nothing. They've told her she was told she had depression. She was told she had anxiety. She was told that she had irritable bowel syndrome. And, I heard her story and I said to her, if I took 100 women to the operating room with your same story, 83 of them would have endometriosis. And she was like, why has no one ever said this to me? And I think it's because we don't get enough training for it in our 4 years of residency as an OB-GYN. I mean, there's a lot to learn in those 4 years. You have to learn how to deliver babies and treat cancer and treat endometriosis there's a million things to learn in those 4 years. And so if you don't take that extra training, then you don't recognize it. And so my job, now that I've had that extra training, is not only to take care of these patients, but to educate other doctors so that even if they're not 100% sure it's endo, that it's in the back of their head, that something like rings a bell and they say, you know what, maybe you need to go see an endometriosis specialist.
Yeah, and also the only way to diagnose is via surgery, which can be scary and also financially inaccessible to a lot of people.
Yeah. Well, that's true. And I think that's part of the problem, right? Is access to care in this country. And so you add the access to care problem on top of the not knowing enough about the disease and recognizing it. And then it's not surprising that we have a 7 to 10 year gap in diagnosis from first symptoms until diagnosis.
Hi, everyone. Pat McCarthy here. Mountainside's Bespoke Recovery offers the highest level of luxury addiction treatment with a focus on your privacy and schedule. You'll receive intense one-on-one therapies from our expert team, enjoy exclusive amenities and concierge service, allowing you to seamlessly integrate healing into your life's commitments. Find out more at mountainside.com.
It's amazing that you guys are accessible too, because there are a lot of, if you Google like specialists for this, there are a lot of different professionals where it's like, yeah, we'll see you. It's going to cost like $15,000 out of pocket. Like, we're not covered by insurance. It's really good care though. And I'm like, it's maybe it's great care, but also who really has that money to spare? And so having accessible healthcare is an immense challenge, not just with this, like in general, but.
Absolutely. I mean, that's a huge issue. And I think that's part of where Representative Gilchrist was, looking at this when she wanted to make this a state program is, we can't just take care of patients that can afford $15,000 surgeries. We need to take care of patients that, don't have insurance or have state insurance. I mean, that's the benefit that I have of working at a state institution is that we will take all comers. Mm-hmm. So it does make a difference.
100%. And this is always, I tell people this, if a hospital has state funding or government funding, they have usually sliding scale, like financial programs. They don't tell you that. And they make it really hard to apply. They're like, you can fax it or deliver it by hand. And I'm like, girl, I'm an hour away. But yeah, that's always something to look into. It's like a little life hack that they don't necessarily want you to know. And so how many patients do you see like on a day-to-day basis? Like, what is your caseload like? So I would imagine you're probably inundated with.
Yeah, so I see patients in the office 2 days a week, and then I do surgery 1 day a week. But I also have 2 colleagues within my group that also see patients 2 days a week. They actually do surgery 2 days a week, each of them, because they have a little less administrative responsibilities than I have. But I am hiring another MIGS fellowship trained surgeon, if anybody's listening, to join me to do the same thing, because we're just the more that we spread the word about endometriosis and the more patients we're getting, and I want to be able to take care of everybody. So I'm hoping to hire another person to join us. But yeah, we probably do somewhere between 200 and 300 cases of just endometriosis a year between the 3 of us. And then the other kind of 100 and change are patients without endometriosis with just fibroids. But a lot of patients with fibroids also have endos, so there's a lot of overlap.
Is there like a connection between those two things? I feel like I read that it was unrelated.
They are generally unrelated, but that being said, we find a lot of patients with endometriosis that have little fibroids, and we find patients with fibroids that have a little bit of endometriosis. So they may be unrelated, but they do seem to travel together.
Yeah.
Maybe parallel play. I don't know.
Yeah, in case one gets lonely.
Yeah, in case one gets lonely.
Yeah.
I love that.
But and also I feel like women, especially when you're getting shut down by doctors a lot, there's a tendency to gaslight yourselves, essentially. This is a kind of a funny anecdote, but after the first time I received endometriosis surgery, they had to call in my husband and my mom earlier than they were supposed to, like after recovery, because I kept trying to leave the hospital because I was embarrassed. I was like, you guys found nothing and I wasted your time and I'm so sorry, I have to go. Yeah. And they were like, no, that's not the case. But it's just, that's like the natural inclination to go to when you've been like fed that for so long that like nothing actually is going on.
Oh, that happens like at least once a week when I do surgery, where I'll go see the patient in the recovery room. And the nurse is actually in the recovery room now. They'll say to me, because they know that sometimes I'll be in my other case when the patient wakes up, they'll say, you found something, right, Dr. Luciano? Because that's the first question they ask when they wake up. And I'll be like, yes, I found something. And so, you know, that's the one nice thing about my chart is that they can immediately look at my op note and see that I found something. And I'll tell the patient that in pre-op. If I'm not there, you can pull up your my chart and the op note's going to be there and it's going to tell you I found something. But I literally have nurses that will say to me, you found something, right? Just so I can tell them when they wake up. And I would say at least 50% of the time my patients wake up, their first question is, did you find it?
That's really validating because I felt very dramatic.
No,
I was trying to break out of the hospital.
You are not dramatic at all. That's how because you have been gaslit for so long that you don't believe that you have something. And your biggest fear is that the doctor's going to go in there and find nothing.
Yeah. The doctor's going to be like, it is anxiety.
Yeah,
it's been anxiety this whole time.
You are crazy.
Yeah,
exactly.
Yeah, female hysteria, yellow wallpaper style, just like.
Exactly.
Yeah. I know. I'm glad you got that reference. I've said that to a couple of people. And they're like, what are you talking about? I'm like, you got to just Google it in your own time. Late night, like you're going through something, just check it out. And so, like we've touched on a lot, the intersection between an autoimmune condition, any sort of chronic illness, and mental health, it can be very devastating. Like in your experience, what does that look like?
So the literature suggests that women with endometriosis have a 5 to 9-fold increased risk of depression and anxiety.
Wow.
And, you know, I mean, that's and that's a chicken and an egg problem, right? Like, is it because they've had all this pain and so they're depressed because they've had the pain? Is it because they've been ignored? Or is it all the inflammation that the endometriosis is causing and we know that inflammation causes changes in neurotransmitters in their brain. We know that it affects, you know, their ability to tolerate pain, that a lot of women with endometriosis, especially when they have a delayed diagnosis or an increased risk for centralized pain conditions, because it's just years and years of firing pain nerves to their brain that have been, you know, either ignored or blown off, that, you know, leads to this kind of, you know, so it's this vicious cycle. And then it's hard to know, you know, is it the anxiety, like, you know, when patients say to me, is it all in my head? Well, no, obviously you have endometriosis lesions, but yes, is the endometriosis affecting your head and the neurotransmitters and your anxiety and depression? No question about it, just like any chronic illness does.
And that can be super validating for, I think, patients. And we have this a lot with clients that we have come through here, especially when they have chronic illnesses. When you like explain the intersection to them and when you can explain the science and the facts of it, it becomes a lot less isolating and a lot less like, I'm crazy or I'm experiencing this and it's not real. Being able to like give it a name and kind of ground the information can be extremely helpful and validating for a lot of people. But when you have a client that, like, are you able to refer out to other providers in the instance if they require more care?
In terms of like mental health care?
Yeah, like
or
mental
just in
health
general?
issues.
Yes, absolutely. And the other thing that, you know, we try to encourage our patients to do is to look into some of the support groups, because, you know, sometimes my patients will say to me, it's too much. And I agree. Sometimes it is too much, right? Like sometimes it's nice to hear that people are going through the same thing as you, but sometimes you're like, I don't want to hear about it anymore. But you have to use a support group like you use anything else, right? You use it for when it benefits you, when it's useful for you to have somebody else hear the things you're saying and validate the things you're saying, versus when it's too much for you. So I do encourage that. I encourage support groups. I encourage therapists. We're hoping to work more with finding people that are interested in doing specifically support groups and therapy for our patients with chronic pain, because I do think that that is important to have that person to talk to about it, because it isn't just about putting somebody on anti-anxiety medicines or antidepressants. Like it's about giving them a space to feel validated and to be able to talk and feel comfortable.
And a lot of times, too, with clients that have co-occurring mental illnesses, especially like mood disorders, they can be very sensitive to hormones, too. And basically, the way that my doctor always broke it down, she's like, the only options are it's like menopause, like induced menopause, or like 3 different kinds of like extreme birth control. And she's like, I'm sorry, but that like that's what we have. And so in the case of having a client that maybe has like bipolar disorder, some sort of schizophrenia, borderline personality disorder, where they are extremely sensitive to hormones, and this is their only option, what does management in that instance look like?
It's really hard. It's really hard. And I mean, I talk all the time about endometriosis being a team sport. We have to work together with everybody. We have to work together with the mental health experts. We have to work together with pelvic floor physical therapists. We have to work together with acupuncture, with massage therapists, with support groups, and then, I can do things like I can do surgery and I can remove those lesions, but we all know that a lot of times they come back. Up to 60% of the time, it'll come back within 5 years. And, I can try medical management that isn't absorbed systemically like a Mirena IUD, but even that's not perfect. And so, that's why we have to work together. We have to find ways, the lowest dose that I can put them on that may mean we have to change a little something with their mental health medications. But again, it's a team sport. I mean, I do the same thing with my patients that have bowel issues. I can remove the endometriosis off of your intestines with the help of my bowel surgeons, but you may still have a lot of inflammation in your pelvis that may cause other bowel symptoms, and you're going to need a gastroenterologist to help us. Or endometriosis is associated with a 5-fold increased risk of migraines. Obviously, me removing lesions from your pelvis isn't going to perfectly fix your migraines, right? So we're going to need to work with your neurologist or with your primary care doctor to figure out when those migraines are happening and if there's something I can do hormonally to help with the migraines. But if there isn't, then maybe we have to come up with a different kind of migraine medicine. So it's a team sport, is the bottom line.
Yeah, and then even some psychiatric I'm in AA and I have a sponsee who is on a mood stabilizer, like a psychiatric medication that its efficacy is affected by estrogen in the body too. So it's like everything. There's so many moving parts, and especially like people who are living with co-occurring issues like substance use disorder, with any sort of problem like that. It can feel like so much day to day. And so having to manage all of these moving parts just to keep yourself functioning can be so exhausting. And I saw I forget exactly what the statistic was, but there's a high rate of women too, once they get diagnosed, not being able to return to work necessarily in some instances, which is obviously massively life-changing.
Yeah, well, and I think that's something that we have to work on as a country, is recognizing that this is a chronic disease that, maybe it needs to be considered, disability is maybe the wrong word, but maybe it needs to be considered something that we can, get work accommodations for. I mean, that I think we need to think about that. But, there's a lot that needs to be done in general for work accommodations, especially for female conditions. So, I think we have a lot of work to do on that. But I think that's part of, again, raising awareness and building recognition for this disease.
And pain management too.
Yeah, absolutely.
Yeah, pain management can be extremely challenging. Like we talked about a little bit before this, like for someone in early recovery to like see a doctor and have a doctor offer them like Oxy 5s, Oxycontin,
Yeah.
like that in itself can that can ruin a life.
Yeah, absolutely
And
it
obviously
can.
it's to be prescribed with discretion, but that can be extremely challenging. And we see that with obviously not just endometriosis or pelvic conditions. We have clients that come through with like nerve pain, like all of these old injuries, and that continues to bring them back. So it's like, yeah, it's ruining my life. I'm losing my house. I'm losing my marriage, but I'm also in so much physical pain that like I
Yeah.
feel like I need this thing.
Yeah. And we need pain management specialists to help us with that. And sometimes I have patients that, that's where we go from the surgery. I mean, I have patients that will, after surgery, they'll be in terrible pain because it's a surgery and I made incisions on your belly.
Yeah.
And yet they're so afraid of getting back on medications because of their history.
Yeah.
And so we really, again, it's about having resources and working together.
That's what I was telling my friend who's a paramedic. I'm like, yeah, pain management. I was saying how after surgery, I would take half a dose in the morning and half at night, and I would be like hobbling around the house, like picture like Quasimodo.
Yeah.
And she was like, just take the full thing. I'm like, I don't know, it freaks me out. But what is so obviously you guys are in the midst of doing a lot of research, a lot of advocacy, and it seems like there's exciting stuff on the horizon. What are some of the outcomes that you're hoping to see from some of the work that you're doing?
So I think our biggest goals are twofold. One, to come up with an early diagnostic test that is not surgery.
It's crazy. It's so crazy. They're like, maybe you have it. We can't tell you unless you let us cut you up. Like crazy.
Crazy. Totally
Yeah.
crazy. So that's number one. But number two, I would love to see targeted therapy, meaning not just throw birth control pills, which, by the way, are meant to protect you from getting pregnant, not to treat endometriosis.
Yeah.
I want something targeted. I would love to have something that recognizes these lesions as not supposed to be there in our body and just attacks just those lesions and doesn't, cause like an atomic bomb in the pelvis, just the lesions, and, protects fertility, because that's the other issue, right? All the medications that we have for endometriosis make it such that you can't get pregnant by definition. And then multiple surgeries doesn't make it better either. So, we need to have something that can target the therapy, target those lesions, and at the same time promote fertility for the women that want it.
Yeah, 100%. Yeah, that would be ideal instead of, like you said, a bomb going off in your pelvis, or even with the some of the medications that induce menopause. Yeah. I thought I was going insane. I put the creamer inside of the plate cabinet. My husband came and found it later, and he was like, "We gotta throw. It's been in there for 48 hours. You gotta throw this away now. How'd this get in here?" I'm like, "I have no idea." Because you just and menopause is a whole other issue, but yeah.
But exactly right. We're treating endometriosis by putting 25-year-old women in menopause. That doesn't make any sense, right? We have to come up with something a little more targeted than that.
Yeah, I'm like, why is my skin so dry?
Right. How's that fixing my endo?
Yeah.
Yeah. And it's not even a cure.
Yeah,
It'd be one thing if it were a cure, right? If I said to you, look, you just have to be in menopause for 6 months and then you'll be cured.
Yeah.
Okay. But I'm saying you got to be in menopause for 6 months, and then once you stop the meds, it's just going to come back.
Yeah, and you could take it for 2 years max because it's so bad for you.
Right.
I was like, what? This is it?
You're right.
Yeah, it's
That's
so
what we got.
crazy. Yeah.
That's what we got.
But yeah, exciting stuff on the horizon. And once again, I love that your foundation makes things accessible for people too, and has a focus on both providers, patients, and researchers. It's really threefold. But I'm so excited to have you here. Thank you for stopping to talk to us, and I look forward to see what you do in the future.
Oh, this is really a pleasure. I just love the chance to talk about our program and to spread awareness.
Awesome, dude. All right. Sorry calling you dude. I just do that.
It's all right. It's all right. My children call me brah.
Oh, yeah.
So we're good.
You've got sons. Yeah, this is old news for you.
Exactly.
And if we want to get in touch with EndoRISE, we want to look into the resources you guys have. Where can we access that?
So our website is ctendorise.org. You can even just put in Google EndoRISE and you'll get our website. Also, you can find us on Instagram and LinkedIn as well.
And what kind of resources do you offer?
So we have a whole patient page that has Connecticut resources, acupuncture. We have nutrition information on there. We have pelvic floor physical therapists. We have lists of providers that do minimally invasive GYN surgery, and then support groups and advocacy groups as well. So we have that whole patient page, and then we have some information just about what we're doing. We also have a fall forum coming up on December 8th at Jackson Labs to learn more about what our program is doing and some of the research and stuff going on for patients. That is free and open to the public, and you can register for that on the website as well.
It's nice that you make it consolidated so you don't have to look 1,000 different places to get everything.
It's all there.
That's convenient. And you can find all of these links in the comments below. All right, thank you.
You're welcome. Thank you.
If you or a loved one is struggling with addiction, Mountainside can help. Call 860-365-6764 to speak with our caring treatment team.